Test 1, 2, 3, 4. Test 1, 2, 3, 4. Test 1, 2, 3, 1, 2, 3, test, test.
Hello, my name is Erica Bonner and I'm an occupational therapist at St. Vincent's East Hospital. I primarily work in the acute care setting and I have been here for a little over a year and a half. I graduated from Itawamba Community College with my associate's degree in occupational therapy in 2015, and I worked as an occupational therapy assistant for about a year before I began the Bridge program at Belmont University in Nashville, Tennessee. I graduated with my master's degree in occupational therapy from Belmont in 2018. Last year, I became a certified lymphedema therapist and received my training from the Norton School of Lymphatic Therapy, which consisted of 45 hours of home study and 90 hours of classroom instruction. I have worked in the outpatient and acute care setting, treating a wide variety of patients across a lifespan over the last 5 years as an OT practitioner. I have no relevant financial or non-financial relationships to disclose during this presentation. Today we will review the anatomy of the lymphatic system, discuss diagnosis and prognosis of lymphedema, explore treatment and management of lymphedema, and we will also review a patient case study. So the lymphatic system is part of the circulatory system, and it consists of a network of lymphatic vessels that carry a clear fluid called lymph. The main function is to collect and transport tissues, fluids from the intercellular spaces in all the tissues of the body back to the venous system. Lymph nodes and other lymphatic organs filter the lymph to remove microorganisms and other foreign particles. At rest, the lymphatic system is pumping at approximately 6 times per minute, and it can pump up to 60 times a minute. Unlike blood, which is pumped by the heart, lymph is not pumped by the heart. Rather, it is moved by the rhythmic pulsation of the lymph vessels and further activated by the muscle contracting and relaxing. So here you can see an outline of the lymphatic system. Today we're going to talk about the cervical lymph nodes, the axillary lymph nodes, and the inguinal lymph nodes. And here's a picture of the circulatory system and the lymphatic system, and also how the lymphatic system intertwines with the venous system. So once interstitial fluid enters the lymphatic system, it is called lymph. The lymphatic system consists of lymphatic loads, which include protein, water, cellular components, and particles and fat. Protein is responsible for cell nutrition, immune defense, and blood coagulation. Water is essential in the body's fluid management and is a solvent for other lymphatic loads. Cells and particles are responsible for the circulation of lymphocytes back into the bloodstream and are essential for immune response. Cancer cells also use the lymphatic system for the formation of metastases and lymph nodes and other tissues. Certain fat compounds in the body cannot be reabsorbed by the blood vessels and are absorbed by the interstitial lymph vessels. Lymph time volume is the amount of fluid the lymphatic system is able to transport in a unit of time. So the lymph time volume is lower when the patient is at rest and higher with activity. The transport capacity is the amount of fluid transported by the lymphatic system at the maximum frequency. Lymph flows through the body through a series of capillaries, precollectors, collectors, nodes, trunks, and ducts. Capillaries absorb lymphatic loads into the lymphatic system. Precollectors absorb and transport lymph. Collectors transport lymph into the lymph nodes and lymphatic trunks. And collectors also transport fluid from the superficial and deep lymphatics as well as the other organ systems to the trunks. Lymph nodes serve a protective and immune function. They filter harmful material such as cancer cells and pathogens in lymph fluid and produce lymphocytes. For the purpose of today, we will only discuss the 6 superficial node beds, which include the axillary, cervical, and inguinal node beds. And there is a node bed on the right and left side of the body. Trunks transport lymph to ducts, and it consists of the jugular, supraclavicular, subclavian, peristernal, and lumbar trunks. And trunks and ducts are part of the deep lymphatic system. Ducts drain the lymph into the venous angle, which allows the lymph to return to the venous system. It consists of the right lymphatic duct and the thoracic duct. The thoracic duct begins at L2, and 3/4 of the lymphatic fluid drains to the left venous angle via the thoracic duct, and the right lymphatic duct drains the remaining 1/4 of the fluid to the right venous angle. It's important to note the location of the thoracic duct and the amount of fluid the thoracic duct drains. Later in this presentation, I will discuss the treatment of lymphedema, and we will discuss the importance of the abdominal sequence and of MLD and diaphragmatic breathing. So what is lymphedema? Lymphedema is caused when the lymphatic system is unable to perform one of its basic functions, remove water and protein from the tissues of certain portions of the body. Lymphedema is caused when the transport capacity of the lymphatic system falls below the normal lymphatic load, which results in an abnormal accumulation of water and proteins in subcutaneous tissue. Lymphedema may be present in the extremities, trunk, abdomen, head and neck, and external genitalia, as well as internal organs. Lymphedema is a chronic lymphatic disease typically with a gradual onset. Lymphedema always moves distal to proximal, so an individual will notice swelling in their hand or foot before they begin to notice swelling in the more proximal regions of their body. If a patient has an onset of proximal edema, a further assessment from the doctor should be performed to rule out any other comorbidities. There are long-term physical and psychosocial consequences from lymphedema. Lymphedema combined with other pathologies such as cardiac and venous insufficiencies can make those diagnoses difficult to manage, and there are many cosmetic deformities that come with lymphedema, which result in fibrosis, cellulitis, lymphangitis, and papillomas. The most common form of lymphedema in the United States is following breast cancer surgery, and particularly in patients who have had an axillary lymph node dissection and undergone radiation therapy. So the question I'm asked the most is kind of what is the difference between lymphedema and edema? With the onset of edema, especially the lower extremity, it's important to rule out other possible diagnoses such as cardiac abnormalities, blood clots, or tumors. The difference between edema and lymphedema is that edema is a high water, low protein edema. Edema is reversible and should go away on its own. Lymphedema is considered to be more of a disease rather than a symptom, and the damage that is done to the lymphatic system, whether it be a developmental abnormality or caused due to surgery, radiation, or trauma, cannot be reversed. Lymphedema is a high protein edema due to the fact that the lymphatic system is unable to filter out excess waste that it should typically filter out. There are several other forms of edema, including pure lipedema, lipolymphedema, lipophlebolymphodema, lympholipedema, and chronic venous insufficiency, and that's just kind of a whole another realm to lymphedema, and it can be treated, those diagnoses can be treated following the protocol for lymphedema, but of course would be altered for that patient's typical diagnosis. So there are two forms of lymphedema, primary and secondary. Primary lymphedema is due to a developmental abnormality or a dysplasia of the lymphatic system. This can be congenital or hereditary. Hypoplasia is the incomplete development of the lymphatic vessels, making the diameter of the vessels smaller than normal. Hyperplasia occurs when there is a malfunction of the valvular system within the collectors, which leads to lymphatic reflux. With hyperplasia, the diameter of the vessels is larger than normal. Aplasia is the absence of either nodes, capillaries, or lymph collectors. A more specific diagnosis of lymphedema is lymphedema precox, which is if the onset is before the age of 35, and lymphedema tarda if the onset is after the age of 35. Secondary lymphedema is caused by radiation, surgery, orthopedic injury, any type of damage to the body that the lymphatic system cannot recover from. With breast cancer-related lymphedema, lymphedema only occurs if lymph nodes are removed or damaged with radiation treatment. So if a woman undergoes a mastectomy due to having a family history of breast cancer, but they do not have lymph nodes removed, they should not be at risk of developing lymphedema. And there is no time frame for when an individual will experience an onset of lymphedema after lymph node removal. Some people experience swelling days to weeks after surgery, while others may not begin to experience swelling for years. So there are 4 stages to lymphedema: stage 0, which is no swelling, and stage 1, where the edema is soft and pitting, there are no secondary tissue changes, and elevation reduces the swelling. Stage 0 and 1 are considered to be the reversible stages with early intervention and management before the lymphatic system is too damaged to manage normal lymphatic loads. At stage 2, the patient will begin to experience lymphostatic fibrosis, hardening of the tissue, the extremity may no longer pit, and the patient may experience more frequent infections. At stage 3, there is an extreme increase in volume and tissue texture changes with evident skin changes. At stage 2 and stage 3, there is a higher chance of the patient contracting a bacterial or fungal infection due to the severe damage of the lymphatic system. So what makes the lymphatic system impaired? There are 3 types of insufficiencies. With dynamic insufficiency, the lymphatic load exceeds the transport capacity of the healthy, intact lymphatic system, which results in the onset of edema. This is common following surgery or injury. It is important to reduce the edema as soon as possible, and this is achieved by the standard rest, ice, elevation, and compression. If the dynamic insufficiency is present for long periods of time, the lymphatic system may become damaged, which results in secondary lymphedema. A mechanical insufficiency literally means the mechanics of the lymphatic system are damaged. So the lymphatic system is either initially damaged or faulty and is unable to manage a normal lymphatic load. And a combined insufficiency occurs when the transport capacity of the lymphatic system is reduced and the volume of the lymphatic load simultaneously elevates. This combination may lead to severe and chronic inflammation in the affected extremity. So complete decongestive therapy is considered the gold standard of care for lymphedema. It is a non-invasive approach and is implemented in 2 phases. With the 2 phases, there's the intensive phase, which consists of complete decongestive therapy to include manual lymphatic drainage, compression therapy, decongestive exercises, and skin care. The length of time a patient is considered to be in phase 1 is dependent on the results of the circumferential measurements at each session. Once there is a plateau in the measurement changes, it is time to transition to phase 2. And phase 2 will be discussed later in this presentation. Manual lymphatic drainage is a gentle manual treatment technique that is based on certain types of strokes and a working phase and a resting phase of each stroke. The strokes are just enough to move the skin. It is not a deep stroke or a retrograde massage. It's a light stretch to the skin that stimulates the lymphatic system and moves fluid in the appropriate directions. With compression therapy, venous and lymphatic return is improved, the effectiveness of the muscle and joint pump during activity improves, and the risk of reaccumulation of evacuated lymph is reduced. Short stretch bandages are used in the treatment of lymphedema. Short stretch bandages have a 60% elasticity and allow for a greater working pressure, meaning the resistance the bandage provides during active muscle contraction and activity is greater. Working pressure results in an increase in tissue pressure, and the lymphatic and venous system are compressed, thus increasing the return of fluids to the vessel system. A long stretch bandage, also known as an ACE bandage, has an extensibility of 140%. This high extensibility creates a low working pressure with activity, and the lymphatic system is minimally stimulated. Long stretch bandages, or ACE bandages, may have a tourniquet effect on the extremity due to a high resting pressure. The bandages may constrict veins and lymph vessels at rest and provide minimal support to the tissues during active muscle contraction. Compression bandages should also be applied in layers and must be applied following a specific pattern and technique. It may be necessary to use padding to protect sensitive or concave areas, and also to use compression foam to bring the extremity into a cylindrical shape. Bandages should be worn 24/7 and can be removed when taking a shower or when the patient is at therapy. Once the limb is decongested, a patient will transition into compression garments. It is very important to not provide a patient with a compression garment without providing proper treatment and decongesting the extremity, as the compression garment alone will not treat the lymphedema. There are a variety of compression gloves and gauntlets, sleeves and stockings. There are several sizes and variations, including circular and flat knit, and there are several compression levels and classes. Compression garments may come in standard sizes or be custom made, depending on what's the best fit for the patient. Compression garments become a part of the patient's everyday life, and this is kind of the part that's tricky to encourage patients to continue with their lymphedema treatment, because they expect to, have their bandages removed and everything be just fine. And if the compression garment is not worn to continuously provide pressure, the lymph will reaccumulate in the extremity, and the patient really kind of has to start back over. In the decongestive phase, patients should perform their exercise and follow their exercise plan while wearing their compression bandages to provide that extra external support to stimulate the lymphatic system. And skincare consists of proper cleansing and moisturizing before garment application, and also once the garment is removed. Patients are also educated to closely monitor the integrity of their skin, which includes areas of redness or areas of localized edema. So with lymphedema, the activation of the interterritorial anastomoses may prevent the onset of swelling as part of the body's own avoidance to lymph stasis. When lymph is accumulated in a certain area, the fluid can be rerouted manually by the use of these anastomoses. So we have the inguinal axillary or axilloinguinal anastomose, depending on which direction you're coming from, the interaxillary and the interinguinal anastomoses, and there's an anterior and posterior for each anastomoses. So when we reroute the fluid through manual lymph drainage, we follow the anastomoses guideline. So for example, if a patient has a left upper extremity lymphedema, lymph may be rerouted via the anterior and posterior interaxillary anastomoses, as well as the anterior and posterior axilloinguinal anastomoses on the left side. So contraindications to complete decongestive therapy include cardiac edema, renal failure, acute infections, acute bronchitis, acute DVTs, malignancies, bronchial asthma, and hypertension. If a patient has cardiac edema combined with lymphedema, manual lymphatic drainage may be indicated, but cardiac and pulmonary functions must be closely monitored. And once a patient has been properly treated and an infection has been medically managed, it is okay to proceed with complete decongestive therapy with caution, and it is important for the patient, therapist, and doctor to be in close communication throughout the treatment process. So unfortunately, there is not a lot of evidence-based literature regarding precautions for lymphedema. These precautions are based upon best practice, clinical experience, and knowledge of the pathophysiology of lymphedema. We encourage patients to use caution and not have their blood pressure taken in the affected extremity. It is recommended to assess the blood pressure manually if both extremities are affected by lymphedema. The intense pressure from the cuff may be enough to exacerbate lymphedema in certain individuals. We also encourage patients to use caution and not have injections or sticks in the affected extremity, because each time you break the skin of the affected extremity, you're increasing that patient's risk of experiencing an infection, because that lymphatic system is already damaged. We encourage patients to avoid heat, which includes taking a hot shower, using hot packs, or getting in hot tubs or saunas, as they may experience a flare-up in their edema. With skincare, we ask patients to pay special attention to any area that may have been cut or injured, and monitor the site to ensure that an infection does not occur. I always encourage patients to err on the side of caution with any type of skin tear or injury. Due to the difference in the cabin pressure during flight, we always encourage patients to use a compression garment when they are flying. So the way that I learn best is to actually see things in action and see results. So I thought it would be beneficial to all of you to actually see before and after photos of a patient that I treated here in the St. Vincent's East outpatient clinic. He has given me permission to share his story and photos for the purposes of this continuing education. So my patient was a 70-year-old male. He had bilateral secondary lower extremity lymphedema. He sustained an orthopedic injury at work in the early 90s. His injuries were non-surgical, and he went through physical therapy, and he said they followed the typical RICE protocol for his swelling, but he noticed that it never seemed to work long term. His legs continued to swell over the years, and then he began to develop skin growths on his legs. He went to his primary care physician, the cardiologist, and the dermatologist as things began to escalate, and unfortunately no one could tell why he was continuing to swell and experience skin changes. One day when he was hospitalized, he was sent home with home health care therapy, and the home health nurse suspected that he had lymphedema and requested that he return to his primary care and receive a referral for lymphedema treatment. So on the day of evaluation, I performed a standard evaluation assessing range of motion and strength, asking about his current functional status and home life. I then assessed his skin integrity, looking for any signs of infection or skin tears, and then I measured each leg. So each leg is measured in 4 centimeter increments, and there's a specific formula used to calculate the total amount of fluid in each leg. So on the day of evaluation, he had 14,395.27 milliliters of fluid in his right leg and 13,567.66 milliliters of fluid in his left leg. You will also notice on the anterior aspect of each of his legs the skin growths, and those are known as papillomas, which are a common skin characteristic in stage 3 lymphedema. So I fit my patient for a reduction kit, and we also use the foot piece of the reduction kit. The reduction kit was to be worn 24/7 with the exception of taking a shower and performing his skincare routine. So with this Velcro kit, each end piece is removable, and as the patient would decongest each week, I would remove the Velcro and cut the strap so that each time he would fasten the reduction kit, he could provide the amount of compression that he needed as he continued to reduce his swelling. We use the reduction kit as an alternative to compression bandaging because the Velcro reduction kit was just much easier for him to manage than multi-layer compression bandaging. Ideally with the lower extremity and upper extremity, you always want to start at the most distal aspect of the extremity and provide pressure proximal to the body. We put the foot piece on his foot just because he had that swelling in his foot, but just due to his age and other factors, he wasn't able to reach all the way down and touch his toes, so we just wrapped as much of his foot as we could. And each session I monitored the swelling and skin integrity of his feet and also encouraged him to do the same to make sure that we weren't pushing fluid towards his feet. So the time between the first 2 photos is 2 weeks and 5 days. The patient was evaluated on August 29th, and at the evaluation, I measured and fit him for the reduction kit. He had to purchase it and wait for it to come back, or for it to be mailed in. So on September 12th, he came to the clinic for his first treatment. So although the pictures are taken 3 weeks apart, the reduction in the size of his legs from picture 1 to picture 2 is evident after only 5 days of wearing the kit. And then in the picture taken on October 10th, which was a month after his treatment began, you can see the swelling is significantly reduced and even the appearance of the papillomas are beginning to disappear. And you can also clearly see how in the first picture his legs look more like a column, and in the second and third picture his legs are beginning to look more like a cone shape. So at discharge, I fit him for the JuxtaFit Premium with compression socks. The compression socks have a little bit of compression from the toes to slightly above the ankles. That was to address the edema still in his foot and in his toes that we just couldn't get out. And then the reduction, the JuxtaFit Premium that he has is very similar to his reduction kit with the Velcro. It was just easier for the patient to get on and off. Typically in this phase at discharge, I would fit a patient for compression garments. But like I said, due to his age and other factors, he wasn't able to get on a tight fitting compression garment. So to increase his compliance with wearing the compression garments, this was the route that we chose. So from August 29th to January 28th, he came back in for his reevaluation, just for me to continue to monitor things after he had been discharged, just to make sure that he wasn't having any skin breakdown, any irritations, or anything that we needed to change. You can clearly see the reduction in the swelling of his legs and the decreased appearance of the papillomas on the front of his shins. This reduction was achieved by manual lymphatic drainage 3 times a week in the outpatient clinic and him also performing self-MLD at home. We used compression bandaging with the reduction kit, which was 24/7, and the reduction was reduced and maintained even further with wearing the Juxtafit from November to January. This patient had excellent compliance with treatment. He never missed a session. He always wore his reduction kit, and he always communicated to me about how he was feeling about his treatment. And he is the exact example of the results that a patient will experience if they're compliant with treatment. So the biggest thing I want you to take away from today is that lymphedema is manageable, but it is not curable. This is kind of the phase 2 of treatment, the self-management phase. So once a patient no longer needs to come to the outpatient clinic for manual lymphatic drainage and to continue to decongest the extremity, they transition into phase 2, which looks a lot like phase 1, but it is their responsibility to perform. They're doing manual lymphatic drainage 2 times daily, managing skin and nail care, continuing to wear their compression garments day and night, and completing their decongestive exercises. After a patient finishes phase 1, I will measure them for a daytime and nighttime garment once their extremity has decongested to the maximum amount. And they will continue to wear that day and night, basically for the rest of their lives. I kind of encourage patients to tell them it's just like how every day you would get up and put on your sock. Well, you're just going to get up and put on this compression sleeve. In order to maintain that level of decongestant in their extremity, external compression has to be applied. So the main goal of complete decongestive therapy and lymphedema treatment is to reduce, maintain, and prevent. If a patient is having a lack of progress or frequent relapses or a permanent increase in lymphedema during the second phase, it may be due to a variety of things such as patient noncompliance, or a patient may be experiencing a reoccurrence of cancer or other associated conditions due to lymphedema. At this time in the treatment, the patient would need to follow up with their referring physician for a more in-depth workup to make sure that there are no contraindications to proceeding with manual lymphatic drainage and CDT. Thank you for your time, and I will be available to answer any questions you may have in the future. Thank you.